them in terms of nationality or ethnicity, they have different entitlement, different living conditions, so different needs. So the idea, thanks to, because of this new migration and the changes in the composition of our patient population, the very idea of diversity has changed to include other dimension of difference. So not only country of origin or birth and ethnicity are important, but we need to include other elements such as immigration status, degree of entitlement, the length of residence, gender, age, and socio-economic status. So there are no culturally unique needs, as the people's needs are expressed by the intersection of those differences that can lead to inequality and discrimination. So what to define an healthcare organization as being responsive in diversity within this new situation? So for a healthcare organization to respond effectively to diversity today, it has to respond effectively not only to migrants and ethnic minorities, but to all socially excluded and vulnerable groups liable to inequities in health or healthcare. Because it's the intersection of the individual characteristics and the social situation that tends to lead to discrimination and exclusion. And this intersection, it's dynamic, it can change from context to context and in different settings. So how an organization should respond to these challenges? By developing a policy measure at organizational level that focus not only on one, but all factors or differences that put vulnerable groups at risk of exclusion, inequities, discrimination. So the approach should be the one of assessing the needs case by case. So at the level of the organization, what should the hospital do? For example, it should develop specific policies and programs that address equity priority in the organization, and they should be written and should be as important as all the other, policy in the organization, should be integrated into the health outcomes and service use of client population, and linking health information to social demographic information. Okay. Improve awareness, knowledge, and build capacity of staff at all levels to address inequity in healthcare. Address barriers that prevent or limit people accessing and benefiting from healthcare services of all kinds that we have described. It has to provide person and family-centered care, always acknowledging the individual characteristics, experience, and living condition of the patient. It has to promote effective participation of the users and community, especially the civil society. So how do we ensure that these policies are effectively implemented and assessed over time? This is a problem because we know now what should be done. It's needed to be done, but we have the problem of implementing these policies. For this reason, as a task force of migrant-friendly hospitals, we have worked and developed a tool that allows healthcare organizations to monitor and measure their capacity to provide for equitable services for a diverse population. These standards have been developed by an international group of experts and professionals, and in doing that we analyzed, we reviewed existing models and standards, and because thanks to that we identified our conceptual framework and identified which are the main areas of the organizations that we need to measure, constantly measure and assess in terms of equity. And then we asked the organizations to give us a feedback on these standards. So we pilot tested these standards in 45 institutions in 12 countries, 10 in Canada, 5 in Australia, the rest in Europe. And the result of this pilot test helped us for developing the final standards. Now we have the final, the conceptual model is based on a theoretical framework that is described in an article that we have recently published, and that which refers to the concept I tackled in the first part of my presentation. The standards cover 5 main areas: equity in policy, equitable access and utilization, equitable quality of care, equity in participation of users and the community, and outside the organization by promoting intersectoral interventions in the community, and especially with the civil society. Now we have the final standards. There are 50 measures that are there, and healthcare organizations are asked to measure the compliance of their services with these measures, and to favor, and I'm really going to the conclusion, to help health organizations to implement these standards, we have recently developed a tool for self-assessment. The whole, and we have just started the pilot test of this tool. There are 14 countries involved, and if there are other institutions interested in this project, they can send us an email, and we'll be happy to include them in the experimentation. Thank you.
Good morning. Can you hear me? Yes. First of all, thank you, Beatrice, for the introduction. I would like to thank the organizers for providing me with this opportunity this morning to share some ideas on a very important but often neglected subject. And I'd also thank all of you, the audience, for turning up on a Saturday morning so early. I need the... Sorry. I thought Antonio had stolen the pointer. This is a very large subject, and we could talk all day. And you can see this is a very beautiful picture of Norway. But because the subject is very large, I'm not going to be able to cover everything, just a small part of what the whole subject matter entails. What I'm going to talk to you, I'm going to talk about some definitions, because we all have different definitions of the terms that we use. Why should we adapt? Should we bother with that at all? When, how, and what to adapt, and the way forward. And basically, I'm going to address 2 main areas. the need to adapt, and how we're going to adapt. So first of all, let's look at some definitions. Health promotion. What do we mean by health promotion? And I'm sorry, it can mean a lot of things to different people, but I'm going to stick to a bit of what WHO has talked about. In very simple, plain language, it is the process of enabling individuals and communities to improve their health. And the basic purpose of health promotion really is that we want to reduce risk and we want to decrease morbidity and mortality. And I think all of you will agree with me on this. If not, we'll meet in the coffee break outside. The other definition that I have here is adaptation. And adaptation is very interesting because we all have different, opinions about what we mean is to adapt. But very simply, if you think about adaptation, it is really the issue that one size does not fit everybody. And therefore, we will need to make some changes. But in our context, in the context of health and in the context of health promotion, what we're looking at is we have successful community interventions and they will require adaptations for exactly the diverse population that Antonia was talking about, the changing populations, settings and context. And why do we want to do that? The whole purpose is because we want the desired outcomes. They are the same, but the way to reach the desired outcomes might be different, and that requires adaptation. And adaptation will also increase the appropriateness and the relevance for the target group. I was already into why we want to adapt, because we want to adapt something that has worked. We don't just suddenly get an idea and try to adapt it without knowing that it will actually function for a group. But in this case, we take different groups, migrants and ethnic minorities. We need to adapt because we need to address some of these barriers, and Antonia went into these barriers. And if we're going to try to address some of them, we will need to adapt. And we also need to, as I said earlier, increase the relevance and increase the chances of success, because we do want to have successful interventions when we're going to use both time and money to adapt. But adapting behavior change to meet the needs of racial and ethnic minority populations has another potential that we often underestimate, both of increasing the effectiveness in the target population, but we've also seen that it actually becomes very useful for the majority population, because we know that if it works in minority populations, it will definitely work for the majority population. But then the question comes, to adapt or not to adapt? And this could be very difficult, because first of all, I'm not saying here that everything needs to be adapted. Not everything can be adapted, and I think that's an important thing. There are some limitations because some things are just so universal that it's not possible. And it's not meant that we should adapt everything for everyone, but for main risk groups. And let me give you an example. For example, if you have a Spanish-speaking group in the, let's say, across the Atlantic in the US, and you need to have an HIV community intervention, inviting them to a public meeting is not going to work. You will have to invite them home to a neighbor, and the Spanish-speaking will agree or disagree whether this is the right thing to do, rather than inviting them to a public meeting. So it's very different. Or in other situations, if you invite a majority white-speaking population to a meeting, they will want an agenda, they will want to go boom, 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 right through the agenda. Whereas if you, for example, invite a Sami population, which is an indigenous population in Norway, they would like to chat, small talk, and maybe at the end of it come to the point, because everything else is so unpleasant. How can you just go onto the agenda and boom, boom, boom? So there has to be a rationale, because you're trying to improve your chances, your success of working with the population. And the main rationale for us is, of course, to prevent disease and improve health outcomes that have been proven clinically effective and also cost effective. So I'm going to try and give you some evidence for adaptation or the need to adapt. And I'm going to talk about what do we understand by the measures. And I have this long list of measures, and it points in all different directions, and you all get very confused. But basically, we have some structural measures. There are laws, regulations, guidelines, and strategies. And usually the structural measures are often universal because they have to be valid for everybody in the population. We also have economic measures like taxes and subsidies, and they're also often used in health promotion, and they also should be valid for the entire population, but it is not always the case. that they're valid for the population. Then we have some physical measures that you've probably heard of when we would like to have a population that is more physically active. And that would be ensuring play areas in schools or bicycle paths, etc. And that again is something that you do for the entire population. And then we have the favorite, the mass media campaigns, because of course when you think of health promotion, immediately you think of mass media campaigns. But this is a bit more complicated, because mass media campaigns are often morally appealing. And we know that in the health sector, we're not very good at mass media campaigns. If we really need to, we need to take a leaf out of the book of some of the private industries. For example, Coca-Cola, if you really want to have a good mass media campaign, because it's morally appealing, it's usually informative, but not too much of information, but it's also very contextual. So I'm going to give you some examples of legislation. I'm here, and if you have any further questions on what the Council of Europe says, Lilia is sitting in the audience, so she's going to answer that. But this is a sort of international agreement that most countries have agreed to, and we agreed to saying that we will do all of this. Then we have laws, and here I'm just showing you just to test whether you're awake early in the morning. It's in Norwegian. Yes, it's all right, so if you can't read it, you're fine. But these are our Norwegian laws, and our Norwegian laws that, again, you know, say some of the same things that the Europe Council recommendations say when it comes to reaching minority groups. And then we have the Norwegian strategy for immigrant health that we're very pleased to have finally after a lot of challenges. And that again embodies overall policy that is enabling and should be good for health promotion. But then let's see, despite of having all of this, does it really work in practice? And I'm going to give you an example from Norway. Sorry, there's going to be a lot of Norwegian examples. I know Norway best. So in Norway, in the early 70s, as you know, there was a very high both prevalence and incidence of cardiovascular disease. And what the government decided, one of the things to do would be a structural measure was to have subsidies on full-fat milk. So the entire population really overnight changed from drinking full-fat milk to low-fat milk. And this was done because the full-fat milk was more expensive than the low-fat milk. And this example has been quoted by WHO several times as a very successful health promotion strategy. But let's look at our immigrants. And this is part of my work in Norway, where we see that ethnic adolescents, that is children of immigrant parents, more than 60% were drinking 1 to 4 glasses of full-fat milk every day. And then you can think, maybe they're building muscle. Yes, but what happened to that health promotion measure that was done in Norway for the majority of the population? Let's look at the adults. Oops, this is not cooperating very well. Okay. And if you look at the adults, you'll see again with the adults as well. If you look at the Norwegian adults, and the men and women, the women are in green, the men, yeah, it's the same color for you. Women are in green and the men are in a sort of purplish color. And you'll see both Norwegian men and women, they're less than 10% who drink, and rightly so, full-fat milk every day. By the way, you don't need to drink full-fat milk. How many people drink in the audience? No, it's fine. You don't have to put up your hands. And you will see that among immigrants, you know, from all different immigrant groups, in the Pakistanis you'll see that it's over 35% of adults drinking that. And what does this mean? And for those of you who are not working with nutrition, please bear with me, but you will see that the energy intake, that the Pakistani women, is 41% fat, and of that, 13% saturated fat. So the drinking the full-fat milk does have something to say. This is a validation study with it. So what happened here? The health promotion measure obviously did not reach the minority population, did not reach the migrants. So should we have adapted it? Do we need to do something to adapt it? Don't answer. The answer is yes, of course. And then what we did was we looked at it and said this was obviously not reaching the minority population. We need to have something that they can identify with. And you can see that, and you might be thinking, she's talking about milk. Why does she have a cup of tea there? And we produced this health information brochure with the community, where again it says, because everybody drinks at least 10 to 12 cups of tea a day, and the cups of tea is all full-fat milk. So it was really telling them how exactly they can make this change come about. So this was one example. We know that health campaigns as health promotion interventions, they are intensive and wide-reaching. There's high intention over a period of time. It sets the agenda. That's important. It gives rise to debate and discussion, and that's why we need the campaigns. So I'm not saying that we don't need the campaigns, and it always touches a nerve, both intellect and emotion. And we have to balance that, because sometimes we're too informative, we have too much on the intellect, and for minorities, maybe we are not working in the right direction. So mass media campaigns are not successful alone, and we need to do much more than that. And I'll give you another example, and most of the studies, if you look at health promotion, and I'm coming to that if you're thinking I'm only now establishing why we need to adapt, they're on smoking cessation, and that's why I'm giving you this picture. And if you look again at Norway and the Norwegian situation, you'll see that the Norwegian men and women, there's been a dramatic reduction in smoking. But if you look at the group of smokers, the highest prevalence is among men from Turkey. Almost 60%, twice as much as the Norwegian population, whereas there are no women from Sri Lanka that smoke, and there is no artifact. We have checked this data inside out. And the reason for this is very interesting, because the campaigns, the mass media campaigns, they were in Norwegian cinema halls, they were in restaurants, you have the anti-smoking laws, so you have the law, you have all of that. But obviously the Turkish men are not going to the restaurants, they're not going to public places, and they're not going to the cinema. So we are not reaching them in the same way as we're reaching the rest of the population. This is a clear indication that we definitely need to adapt the measures that exist. So I hope I've convinced you of that. The next thing is what needs to be adapted. There are messages, there are approaches, there are methods, there's communication. And we haven't heard a lot about communication in this particular conference, but I know in previous conferences we've talked a lot about how we communicate, with whom we communicate, the use of interpreters. And today I'd like to bring one other aspect that we haven't talked at all about, and it's rather undermined, and that's the whole issue of health literacy. And Antonio mentioned that as one of the barriers, and I think we need to be talking more about that, and of course about the channels. So health literacy is not just the ability for you to read and write, but it is also the ability to be able to comprehend the message and take action based on that. And that is something we undervalue, because even if you've had university education, you may not understand the message or the material. And often I have to say we're all guilty. When we produce materials, we more or less produce them for ourselves. I mean, they're scientifically excellent. The message is very, very good. The language is often used either by doctors, nurses, health professionals, or worse still, I hope there are not many lawyers in this audience, the lawyers, because the legalese is almost impossible to understand. So therefore, we really need the health literacy. Because health literacy is a key determinant of health. We know that high literacy rates benefit societies. We know that low health literacy or limited health literacy follows a social gradient. We know that building these health literacy skills and abilities is a lifelong process. And we know the capacity and competence related to health literacy varies according to context, culture, and setting. We also know that it has a direct impact or affects health outcomes and is a predictor of poor health. And it's also associated with high health system costs. And certain groups are more vulnerable. And it's not, health literacy is something which is something for the entire population and for diverse populations. But more so, and in particular, migrants go lower on literacy and health literacy measures. And migrants have poorer access to use and less information and health promotion, disease prevention and care services. So they're definitely, and this is again a way that if we improve health literacy, we will definitely benefit the migrants, but we will also benefit others. And I think this is something that we really undervalue. And it's also an area that is something where we can't work on it alone, but an intersectoral approach is really required here. Okay, how to adapt? I'm not going to be able to tell everybody here how to adapt, and I was hoping that you could all refer to our good colleagues in Scotland who've done enormous amounts of work on this, so any questions can be referred to them in the break. But they have produced some very good studies, and one of the studies that they've done is adapting health promotion interventions to meet the needs of ethnic minority groups, mixed methods, evidence. So the evidence does exist, but often we're not looking for it. Now, I have to make a correction here. While there's a vast body of evidence on health promotion interventions, the body of evidence on adapting is scarce. And all of you here and all of us need to work systematically at looking at adapting that and how to deliver best. And here again we have some limitations, because when we look at the interventions, they're mainly smoking cessation, as I said. Lifestyle is harder to document. Because in the US a lot of the studies are done on either black populations or Chinese, and in Europe there have been studies from Scotland, as I said, Scotland, UK and Norway, and again the focus there is on South Asian populations. And though we find that adapting these interventions does make an effect, we haven't really studied the effectiveness in terms of better health outcomes. So we need to look at this in a long-term perspective, and we need more head-to-head comparisons of adapted compared with standard interventions. But the evidence base, if I can summarize this, and I would recommend all of you who are planning to adapt anything to read this paper. And it's a very good systematic review done by Netto and colleagues, and they came out with 5 very simple principles. When you read this paper, and I'm just going to outline these principles for you, it is so implicit. Yes, it is, but we have to make it explicit. It says, use community resources to publicize the interventions and increase accessibility. How often do we involve the users? We sit, we plan, we design, we send all our proposals, and then finally we say, oh, we should call somebody from the community, and we just want them to rubber stamp everything we've done. And that's not the way to do it. We need to identify the barriers to access and participation. We need to have appropriate communication strategies so that immediately when we start talking to them, they don't get completely turned off. We need to work with religious or cultural values that either promote or hinder behavioral change. For example, for the Chinese, persistence is a very important value, and that is excellent in the case of smoking cessation, because that helps them to quit. And we have to accommodate varying degrees of cultural identification, because as Antonio said, there are varying groups of migrants. There are some people who might consider them both, like myself, both Norwegian and Indian, and you don't then want to say this is how the Indians do it or this is how the Norwegians do it. So you have to identify where exactly is this particular group. For all of you wondering, oh goodness, how are we going to do it? Our colleagues again have developed a fantastic adaptation toolkit, and basically it consists of 46 items of typology of adaptation approaches. It has a pathway of adaptation which shows how to use the typology. So they've done work not entirely on the theoretical framework, but some of it, and they have reset a decision tool that provides practical guidelines on adaptations to use in different contexts. 2 minutes? Okay, here's the checklist. So I hope I've now also shown you that it can be done, because often we think that it's far too difficult to adapt, it's very expensive, do we really need to do it, all of that. But when you have decided to adapt, you have to have a checklist. Decide that it's worth adapting, and you need evidence and documentation that both the measure has been successful, that you're going to adapt, and that it is really required for this particular target group. You have to assess the situation. You have to do a stakeholder analysis, check the readiness of the target group. If the Turkish men in Oslo are not ready to accept the intervention that we're planning, no amount of convincing will do any good, and we can spend lots of money. So we have to identify, talk to the group, tell them that this is how we are thinking we can do this, get their feedback. And then you have to have a vision. You have to say, okay, by adapting this intervention, where do we want to be? And we have to have concrete outcomes for the intervention. We have to prepare for the adaptation. Do your research, talk to people, spend time with the community, design and develop the intervention with all the stakeholders, pilot the intervention. I think that's very important, because even though everything looks very good and we have a whole lot of evidence, we might forget one little factor in that community that might stands between success and failure. Implementation is important, but another plea to all of you, we all do wonderful things, and you find so many interesting models and wonderful projects, but we don't document, we don't write about it, we don't tell others about it, and that's really a shame. So please document. I think that's very important, so other people can learn from that. The way forward is the following. We need to understand the rationale. for adaptation. I think it's very important before we set off all these adaptations. User involvement, the target group, getting them it's really the basis for improving health, and it's empowering the users. Because unless we empower the users, health promotion is of absolutely no value. We need to contribute as scientists to generate evidence, studies that will provide valuable empirical evidence, and they need to be pursued. We need to build skills and competence, because this is not something we can just decide, okay, we'll do it and, we get on with it. But we really have to work systematically with that, both health providers and researchers, to develop approaches in adapting interventions. That has not been the case so far. I'd like to end with a quote from Gandhi, and says that you have to be the change that you want to see in this world. Thank you very much.
Thank you very much for your excellent presentations. And as we have to adapt to the scheduled time, so please, I ask you to be very brief so that you can have a few questions, okay? Okay, good. Excellent.
I'm too tired.
Are you tired?
No, the audience.
No, not at all. So, okay.
István Szilárd from the University of Pécs, Hungary. It is not a question because we were happy to hear two excellent presentations. It's rather a comment, so that it was really impressive to recognize the differences when you are representing the health service providers angle, and when you are speaking about on community level intervention, because exactly so that when you are focusing more on individuals as patients or clients, all of those additional factors, then not only the culture and culture should be considered, and that's clear, and I was really very happy to hear it. Of course, that the social determinants of health should be considered as well. But when you are focusing on community level intervention, then the cultural anthropological issues, cultural competence, should play a much significant role. Just an example from Hungary. So that when we are providing health promotion intervention programs for Roma communities in Hungary, it's, speaking frankly, not a question whether are the funds, are the financial means in the background of the programs, and in spite of this, they are not really working because most of these programs are considering under the umbrella of poverty, and it is not matched, designed specifically to the Roma population, to those health beliefs, has related standards, what a Roma community would represent, and what they will accept from somebody who is coming outside and start to speak about health promotion activities. So thank you. To me, it was the main what I have learned from today, that it's totally not a different, but a different angle and approach when the individual health assistance service and when a community level health intervention. Thank you so much.
Thank you. If you don't mind, I give some more words, and at the end you answer, because we are out of time. Okay.
Thank you. Thank you very much to both speakers. I'm from Dublin, Ireland, Public Health Nursing Services, and my comments really are directed mostly towards Antonio's to do with the cultural competence models and within the primary healthcare service and the hospital service. I'm conscious that most of the people here, we're speaking to the converted, like most conferences and seminars, in terms of people's commitment. But the issue of undertaking cultural competence training and education, I think most models lack an emphasis on the safety element for healthcare professionals, where they can feel trustworthy in undertaking such training, because it really, if change is to occur, it involves personal reflection. And really the elephant in the room is the ethnocentrism that exists within any healthcare discipline, in which there's such a lack of evidence in the literature. And I think cultural competence training and education, whether it occurs in a formal education setting or informal collaborative types of models, must address that issue, and particularly the safety, where healthcare professionals can discuss this in realistic, facilitated, safe ways. And I'm just wondering how that's encompassed in the MFH model. Thank you.
Someone else? One? Okay, so you can.
Not quite sure about the designated safety.
Patient safety. You want me to
Patient safety.
You want me to answer? No? Okay, we have a division of labor. I take all the easy questions, Antonio takes all the difficult questions, but luckily we don't have so many questions. I'd like to start off with the issue that you raised, our colleague from Ireland, and I couldn't agree with you more. We are really talking to the convinced, we're preaching to the choir here. But I think, again, I have to get back to documentation, and that's why I don't know if Marie is here. Yes, I can see Marie here. Marie is here from the Netherlands, and we decided that one of the things we need to do is we need to document this. We need to document it for the teachers who teach the health professionals about these issues, because the teachers themselves are not very clear, and we have this collaborative project, which is, I think we're 10 countries, 12 universities in Europe, and I think Marie had a session yesterday which is really called the training of the trainers, because unless you get the training of the trainers, but you will have the odd physician, you will have the odd health professional, you will have the odd nurse who will have this kind of attitude that has been there already, which is very ethnocentric. So I'm very glad you bring about the elephant, you talk about the elephant in the room. So, but we have realized that the only way to actually get rid of the elephant is by having the evidence, the documentation. And that hopefully at the next EUPHA conference we might have some results from this particular project that we can then share and say how we're going to go about it. Because changing attitudes of teachers who have been teaching the same curriculum for the last 25 years is not easy. So it is an uphill task, but I think we need to do that. The other issue that you brought about, which is patient safety, if I understand that correctly, and I think patient safety issues are also becoming the core when we discuss translation, because translation was earlier on considered it's for the patient, it's actually for the health professional, health provider, as much and even more so if they're going to really be able to consider patient safety in any serious manner. So it's again, there's a paradigm shift there. The translation is also not because of only culture, and it's because we want to be benevolent to a patient who doesn't speak the language, but also because we as health professionals need that to do our jobs. So I hope that that's, talks about a couple of those things. And I would like to just comment a little bit on your comment. And I'm very glad that, Antonia and I worked very hard to sort of have both aspects, and please, it's not either or. I think we need both of it, and it's important in the health provider situation what you do, and at the community what you do. And sometimes you have to use a mix of the strategies and approaches. So I think that's one of the things I wanted to start off my lecture by saying, my talk by saying, I don't have any recipes that I can share, and I hope you don't go back thinking this is the recipe of how to do it. We have the ingredients, but how you put it together is really up to every single situation, and you need to assess that. So I hope all of you will do that. Thank you.
Very good. Very good.
I cannot add anything after you have told.
Okay. Then it's time now. So I think we have learned a lot altogether with the adaptation, the collaborative project on indicators of equity. You have the book, the report outside, so I am rushing to pick one of the reports about cultural competences, about health Darwinism, how to adapt, we can copy from the private industry and their marketing efforts so effective, so that we can translate them into the health field. So thank you to both, and so thank you to you also.